welcome to the module of sports injuries. Here we will be discussing about the injuries around the knee, particularly because everything else we have either discussed in upper limb trauma or lower limb trauma. So mostly we will be talking about injuries around the knee. The first thing you should understand is that sports injuries are usually low velocity injuries. They are not the typical high velocity road traffic accidents. They're usually low velocity injuries, relatively, meaning you sprain your ligament or you strain your tendon, there is a tendon injury or ligament injury. These kind of injuries are your sports injuries. So it can either be a strain where you injure your tendon or a sprain where you injure your ligament. The most commonly injured tendon in your body obviously is supraspinatus, followed by tendoachillis, which we have already discussed in upper limb rotator cuff injuries. Now, ligaments, the most commonly injured ligament in your body, and most of you have injured it at least once in your life, is when you have sprained your ankle, is the anterior talofibular ligament, right? Anterior talofibular ligament is the most commonly injured ligament in the body. Now we are talking about the knee now. And the structures that we are going to talk about in knee are the collateral ligaments, the menisci, and the cruciate. Basically, the sports injuries that we'll be discussing are under three important headings: collaterals, menisci, and cruciate. But before we do that, we need to quickly review the anatomy, right? So this is an image of the knee joint showing you from anterior. This is the femur, this is the tibia, and this is the fibula. Now, you notice that there is a ligament that runs from the medial condyle of the femur and goes and attaches to the medial condyle of the tibia. This is the medial collateral ligament, also known as the tibial collateral ligament. You also notice that there is another ligament on the lateral aspect of the distal end of the femur from the lateral epicondyle, goes and inserts on the head of the fibula. This is the lateral collateral ligament, also known as the fibular collateral ligament. Okay. Now, if you pay attention, you will notice that the medial collateral ligament is adherent to the medial meniscus, which is this structure here on the medial side, and lateral meniscus is this structure on this side. The medial collateral ligament, or MCL, is adherent to the medial meniscus, and please keep this in mind. And this is what makes medial meniscus injuries more common, because medial meniscus now is more vulnerable to injuries because it is adherent to MCL. It is tethered, it's not free. Whereas the lateral meniscus is free from the lateral collateral ligament. And you can also notice the tendon passing between these two structures, proving that they are away from each other. This tendon is sometimes asked as an MCQ, is a popliteus tendon, is the tendon of popliteus. Anyways, now menisci, both medial and lateral menisci, are attached to the tibia with the help of coronary ligaments. And again, listen to me, like I have done for almost all the modules, friends. Everything is written in the PPT. I just want you to listen to me, pay attention. Once the PPT comes where everything is written, you can pause and write it down. You can make your beautiful notes, but listen to me first, okay? So these are coronary ligaments, the ligaments that attach the menisci to the tibia. Coronary ligaments. Coronary ligaments. Okay? Anyways, now, so we have talked about two collateral ligaments, the medial and the lateral collateral ligament. We have talked about the two menisci, the medial and the lateral menisci. Now there are two cruciate, the anterior cruciate ligament and the posterior cruciate ligament. Anterior is anterior, posterior is posterior. You will notice that this is the anterior cruciate ligament and behind it is the posterior cruciate ligament. If you pay attention closely, you will notice that the ACL attaches to the lateral condyle, PCL attaches to the medial condyle. And if you want to be more specific, ACL attaches to the medial part of the lateral condyle and PCL attaches to the lateral part of the medial condyle, because this is the medial condyle, this is the lateral part of it, and this is the medial part of it. Okay, it's just semantics. We're just using words to describe things that are obvious, right? So this is about the anterior view. What about from behind? How will it from behind? It's again femur, tibia, fibula, medial collateral ligament adherent to the medial meniscus, lateral collateral ligament not adherent to the lateral meniscus, PCL and ACL. Okay, lateral meniscus and medial meniscus. Okay, let me show you the same thing from top now. Again, this is the anterior, this is the lateral, this is the medial, and obviously this will be the posterior. This is the medial meniscus, the lateral meniscus, this is the ACL, this is the PCL. You notice that the MCL is adherent to the medial meniscus and LCL is not adherent to the lateral meniscus. Sometimes you should also know the attachments of the ACL and PCL. ACL attaches from the anterior tibial spine, and PCL attaches just behind the articular surface of the tibia, just behind the articular surface of the tibia. Okay, so this is just a quick recap of the anatomy around the knee, and these are the talking points. The medial collateral ligament we have discussed. We have talked about their anatomy and their location. The lateral collateral ligament we have talked about where it is attached and how it is not adherent to the lateral meniscus. The medial meniscus is attached to the medial collateral ligament. The lateral meniscus is not attached to the lateral collateral ligament. Coronary ligaments are attach the menisci to the tibia, and cruciate ligaments are known as cruciate because they cross each other. They cross each other both planes. ACL goes from anterior to posterior, PCL goes from posterior to anterior, and ACL goes from medial to lateral, and PCL goes from lateral to medial. They cross each other, hence they are called cruciate ligaments. Okay, I've told you that ACL is attached to the anterior tibial spine and PCL attached to the articulars just behind the articular surface. Now, the most important thing that I want to discuss now is where are they located in terms of the capsule. You see both collateral ligaments, the medial and lateral. Let me just clear this for you. Both the collaterals, whether it is medial or collateral ligament, medial or lateral collateral ligaments, are outside the capsule of the knee joint. So they are essentially extracapsular structures. So collaterals are extracapsular. Everything is written, friends. Everything is written. Listen, they are extracapsular structures. Now, the menisci and cruciate, they are intracapsular structures. So menisci, and again everything is written, are intracapsular structures. But please remember, the intracapsular structures are also differentiated between structures that are intrasynovium and extrasynovium. The menisci is intrasynovial, means it's inside the synovial sheath or the synovial layer of the joint, whereas the cruciate are extrasynovial. Although intracapsular, they're extrasynovial. Okay? So ye dekh lo, look at this. Collaterals are extracapsular structures, meaning they're outside the capsule. So end of the story, they're outside the capsule, nothing to worry about. Menisci are intracapsular and intrasynovial, but cruciates are although intracapsular but extrasynovial. This is important and this is critical because when a structure is outside the capsule, you will understand that there is no role of arthroscopy for it, because arthroscopy is a very important modality of treatment and diagnosis of ligament injuries around the knee. When MCL and LCL are extracapsular structures, how will you visualize them? By doing an arthroscopy. Arthroscopy is when you put a scope inside the joint. They are extracapsular structures. You will not visualize them on intracapsular arthroscopy. Okay? Keep that in mind. Right? So it's a potential trap. They ask you a question around this. Anyways, so what are we going to do about doing? We know that we are going to study these 3 headings. So 6 structures under the 3 headings. How will you read about it? Firstly, we'll quickly review their anatomy and we'll try to understand what their function is. Why did God give you these structures? Then we'll try to understand how they are injured. Once we understand how they are injured, we'll talk about how they present to you clinically. How they present to you clinically. Then how do you diagnose it clinically based on your provocative testing? How do you diagnose it radiologically? And finally, how do you treat it? So these are the headings that we will be using to cover everything that we will discuss now. So let's start with collaterals. There are 2 collaterals, MCL and LCL, right? Medial collateral ligament and lateral collateral ligament. What do we already know about it? We know their attachments. We know that they are extracapsular structures. Now, what is their function? Why did God give you them? They are coronal plane stabilizers. Very important. Coronal plane stabilizers. Now, what is coronal plane? This plane is the coronal plane. So they stabilize the knee in the coronal plane, meaning that they will not allow the knee to go into coronal plane. They will not allow the knee to go into abnormal coronal plane, meaning your leg should not go like this. This is the coronal plane. Normally it should not go. So MCL and LCL provide coronal plane stability. So what is the function of MCL? The function of MCL is to resist valgus force. You can obviously see now. This MCL will resist valgus force. What is the function of LCL? LCL will resist varus force. LCL will resist varus force. I am showing you here. I'll show you the image. I'll make you write it down also. So when they are coronal plane stabilizers, they resist varus and valgus force, or in other words, resist adduction and abduction force. Okay? Valgus is abduction force, varus is adduction force. Let me show you this. Look at this. This is femur. tibia, fibula. So this is lateral side, this is the medial side. This is which force? Where the limb is going away from the midline. This is valgus force. Valgus force means abduction force. So which will get injured, or which is resisting, which structure is resisting? MCL is resisting valgus force. That is its function. Right. Now look at this. Tibia, fibula, midline, limb going towards the midline. So this is which force? Varus force or adduction force. What is resisting varus force? This ligament LCL. LCL is resisting varus force. MCL is resisting valgus force. This is their function. They resist these forces. Obviously, you can imagine if this force is increased, they will get injured. But we will talk about that in injuries. Okay. So what is the function of collaterals, friends? Collaterals is coronal plane stabilizers. MCL resists valgus force or abduction force. LCL resists varus force or adduction force. Okay? Slowly, baby steps. Now menisci. What is the function of menisci? Menisci are these semilunar cartilages sitting over the tibia. Tibia is flat relatively, right? And the distal femur is a globular sphere. So how do you imagine a flat surface accommodating the globular sphere of the distal femur? It does not properly. So these menisci essentially add depth to the tibial plateau. So what is their function basically? Their function is to accommodate the femur, number one. Number two, their function is to shock absorb. Their function is to absorb the shock between the femur and the tibia. So normally, if there is no menisci, you would hear this sound. You don't want that. That's why God has given you meniscus, shock absorbers. And very importantly, menisci are rotational stabilizers of the knee. They provide rotational stability to the knee. Okay? They do not allow for the knee to rotate beyond the physiological limit. So look at this. They are the rotational stabilizers of the knee. They are shock absorbers. They are semilunar structures that keep the knee stable to accommodate the femur on tibia. Okay, obviously, how will they get injured? If you rotate the knee. So rotational injuries or rotational forces will injure them. Okay. If you recall from the basics, menisci is which type of collagen? Type 1 collagen. Very good. Menisci is type 1 collagen. The functions of collaterals is coronal plane stability. Function of menisci is rotational stabilizers. What about cruciate? Cruciates are sagittal stabilizers. Sagittal plane stabilizers. Let me show you. Now what do you mean sagittal plane? This plane is sagittal plane. Now what are the movements that occur in the sagittal plane? Extension and flexion. Flexion and extension of the knee. These are the movements that occur in the sagittal plane. So ACL and PCL stabilize the knee in this plane. They prevent what? They prevent hyperextension and anterior translation. They prevent hyperflexion and posterior translation. They do that. So let me show you what does what. They are sagittal plane stabilizers. ACL prevents hyperextension of the knee. Can you appreciate this? Hyperextension of the knee. ACL prevents anterior translation of tibia. PCL prevents hyperflexion of the knee. PCL prevents posterior translation of tibia. So ACL prevents this. PCL prevents this. Is that clear? So they are sagittal plane stabilizers. ACL prevents anterior translation and hyperextension of the knee. PCL prevents posterior translation and hyperflexion of the knee. Now can we summarize their function together? Yes, very simple. This table is there. Collateral ligaments, coronal plane stabilizers, valgus and varus plane, medial collateral ligament and lateral collateral ligament. Right. Medial collateral ligament prevents valgus force or abduction force. Lateral collateral ligament prevents varus force or adduction force. ठीक है ना? Menisci, rotational stabilizers and shock absorbers. Cruciate, sagittal plane stabilizers. ACL prevents anterior translation and hyperextension. PCL prevents posterior translation and hyperflexion. Okay? Is this clear? So this is the review of their function. Now, how can they get injured? Simple, very simple. How can they get injured? Whatever they resist, if the force is beyond their physiological capacity, they'll get injured. For example, MCL resists valgus or abduction force. Apply valgus and abduction force, after a certain limit, MCL will tear. LCL resists varus and adduction force. Provide varus and adduction force beyond the physiological capacity, LCL will tear. Rotational injury, menisci will tear. Hyperextension or anterior translation of tibia, ACL will tear. Hyperflexion or posterior translation of tibia, PCL will tear. That is what it is. Valgus and varus injury, coronal plane force will injure collateral ligament. Twisting injury, rotational force will injure meniscus. Flexion and extension, sagittal plane force will injure cruciate. Look at this. Collaterals will get injured by valgus force or varus force. Menisci will get injured by rotational force or twisting injury or torsional force. Just fancy terms for the same thing. Cruciate will get injured if there is anterior translation or hyperextension, posterior translation or hyperflexion or sagittal plane force. Okay? Are you following me? Are you still with me? Yes. So again, what structure will get injured here? What force is this? This is valgus force or abduction force. And what will tear here? MCL in collaterals. This is varus force, adduction force. What will tear? LCL. Right? For menisci, what do you need? I told you, you need rotational. They are rotational stabilizers of the knee. How do they get injured? To torsion, twisting force. Torsion or twisting force. Now, this is important. For the knee to twist, friends, you stand up yourself. What will you notice when you stand? If your knee is fully extended, it will never twist. When your knee is fully extended, it will not twist. But for it to twist, you need to flex it a little. Just after little flexion, it will only start twisting. So for twisting injury of the knee, what do you need? You need flexion of the knee. So what kind of force will injure the meniscus? Rotational or torsional or twisting of the knee when the knee is flexed. This is important. Of the two menisci, which is more commonly injured? Tell me. The medial meniscus, because it is tethered. Okay. So torsional or twisting force on a flexed knee is the mechanism of injury for meniscus. Now, so what are the clinical features now? What are the clinical features? What will the patient complain of whenever the meniscus is injured? We will review this again, but just a few points here. See, remember, twisting injury of the meniscus is a classical complaint. The patient will tell you that he or she has twisted her or his knee. But following the twist, immediately nothing happens. But hours or days later, they will notice a delayed effusion. Mild to moderate effusion of the knee. Now, what is this? This is because meniscus is injured. Now, when meniscus is injured, the torn piece of meniscus will come between the gliding movement of the femur and tibia. And this torn meniscus will prevent the tibia and femur to easily glide. And this is when the patient will tell you, sir, I am noticing that I am unable to fully extend my knee. That is what is called as pathological locking of the knee or a decreased range of movement. Pathological locking or decreased range of movement. Very, very important. Classical. Okay. Now, what is the most common type of meniscal tear? Bucket handle tear. What happens is the partial tear of the meniscus will start spreading and give you a bucket handle tear. Alright. Now, so what will be the story here? The story will be a patient or an athlete playing sport, twists his knee and falls down. After falling down, he or she gets up, resumes the sport, goes back home, gets up the next day. Next day, when the patient is walking somewhere, suddenly they will notice that they are unable to fully extend the knee. And they will observe that there is knee slightly swollen. This will be the classical story of a patient who presents to you with meniscal injury. Okay? This is the story of meniscal injury. Just keep this in your mind. The next structure that can get injured are the cruciate. Cruciate, what is the mechanism of injury? I have told you, to injure ACL, you either need to go into hyperextension or translate the tibia anteriorly, because that is their function to resist. To injure ACL, your tibia needs to go anterior translation or tibia needs to go into hyperextension. To injure PCL, your tibia needs to go into posterior translation or the knee needs to go into hyperflexion. Right? So look at this image here. Hyperextension injury of the knee. What will injure? ACL will injure. Anterior translation of tibia, what will injure? ACL will injure. And for PCL to injure, what do you need? You need a dashboard injury. In dashboard injury, what happens? Your knee hits the dashboard, the tibia translates posteriorly. On translation posteriorly, what will tear, friends? PCL will tear. Also, you must have seen certain athletes after scoring a goal, soccer players particularly, they celebrate, they run and they slide on the grass. When they slide, they hyperflex their knee and this can injure the PCL. Or rugby players, while running, they will get tackled and their tibia will hit somebody's helmet and their tibia will translate posteriorly. What will tear? PCL will tear. PCL will tear. Okay? So now quickly review the clinical features of a patient who tears their cruciate. So we recall that cruciate are sagittal plane stabilizers. ACL prevents anterior translation of tibia, prevents hyperextension of the knee. PCL prevents posterior translation of tibia and hyperflexion of knee. So how will they get injured? Hyperextension of the knee, dashboard injury. Right? Dashboard injury. Now please understand that patients, when they tear ACL or PCL, they complain of very important sign. They complain of instability. Instability of the knee. Particularly on going up or down the stairs. Up or down stairs. Okay, up or down stairs. Usually it is for ACL and PCL both, but for the sake of MCQ, remember, ACL tear will have difficulty going down the stairs. PCL tear will have difficulty going up the stairs. But in reality, it is very confusing. It's not so clear cut, not so well defined. But for the sake of MCQs, I'll accept this. People with ACL tear will have difficulty going down the stairs. People with PCL tear will have difficulty going up the stairs. But in reality, these are also athletes. These people also twist their knee. But this twisting of cruciate ligament injury versus the twisting of meniscal injury, this is the important part. When a patient twists his knee, he will hear a pop. And this pop is usually the pop of rupture of ACL. And the patient who twists his knee and ruptures the ACL will have immediate hemarthrosis or swelling of the knee. This is in contrast to meniscal injury, where there is a twisting injury also, but there is a delayed effusion. Now, why am I saying that cruciate will also give you twisting injury? Because the athletes, they don't understand what has happened to their knee. They will say twisting injury. Everybody will say twisting injury. Any injury to the knee, the patient will say twisting injury. But if there is a pop, that pop is suggesting that a ligament is torn. Okay? This is what I wanted to understand about the mechanisms of injury. Quickly review this. Collaterals, valgus and varus force, MCL and LCL. Menisci, rotational or twisting or torsional force. Cruciates, hyperextension, anterior translation for ACL, hyperflexion or posterior translation for PCL. Okay? So this is in contrast. We have understood their anatomy, we have understood their function, we have understood how they are injured also. Now trying to go into little more detail. Collaterals again. Which of the two collaterals will injure more? Among the collaterals, MCL will injure more than lateral collateral ligament. Now, how do you diagnose this? We've talked about the anatomy. We've talked about their function. We've talked about how they get injured. Now, let's talk about how do you diagnose them clinically and then radiologically. MCL, how do you diagnose it? We have provocative tests. What kind of provocative test do you have? Stretch it, whatever they were resisting. Look at this. Most common ligament injured around the knee is MCL. What is the function of MCL? Coronal plane stabilizers. Resist valgus force. Resist abduction force. How will you test it? Give valgus force. Give abduction. If the patient complains of pain, it means MCL is torn. Okay. Since MCL and LCL resist valgus and varus force, they are coronal plane stabilizers. Their clinical test is to stress with valgus and abduction or varus and adduction. So look at this. We take the patient. We make them lie down. We flex the knee to 30 degrees. Not full extension, 30 degrees. And now we apply valgus or abduction force. When you're applying valgus or abduction force, friends, which ligament are you testing? LCL or MCL? When you're applying valgus force, you're testing MCL. Let me show you here. Take the patient, flex the knee to 30 degrees and apply valgus force. When you're applying valgus stress test, what are you injuring? You're injuring MCL or you're testing MCL. You're provoking the pain in MCL. Varus stress test is you're provoking the LCL. Varus stress test is for lateral collateral ligament and valgus stress test is for medial collateral ligament. And both these stress tests you perform in 30 degrees of flexion because that is the angle at which these collateral ligaments are maximally stretched and activated, not in full extension. You can perform it in full extension, but other ligaments also play a role there. But at 30 degrees of flexion, it's isolated MCL and LCL that you are resisting. ठीक है? समझे? Now let's demonstrate the valgus and varus stress test of the knee. Now can you tell me what are these tests for? These tests are to assess the integrity of the medial and the lateral collateral ligaments. Can you tell me what is the purpose of medial and lateral collateral ligaments? The medial and lateral collateral ligaments provide coronal plane stability. Coronal plane stability. They are the coronal plane stabilizers. So let's quickly see what their action is. The action of the medial collateral ligament is to prevent the valgus of the leg, and the action of the lateral collateral ligament is to prevent the varus of the leg. And how do they get injured? If you apply a valgus force, the MCL will get injured, and if you apply the varus force, the LCL will get injured. Now the aim of the test is to provoke the symptoms of their injury, that is pain, or to open up the joint on application of the force. So let me show what I'm doing. I'm going to do this and I'll show it on the bone first, and then you'll appreciate it better. I'll flex the knee to 30 degrees. This is important because if I do it in full extension, the injury of other ligaments can confuse the diagnosis. But on 30 degrees of flexion, we are only going to test the collaterals in isolation. So preferably go for a 30 degrees of flexion of the knee. Now once the knee is flexed to 30 degrees, you take hold of the tibia distally at the distal end, and then you apply the valgus force. Now please understand that you're using your left hand as a fulcrum on the lateral aspect of the knee, and you're using your right hand to pull the tibia in valgus or varus. Now how will you assess where the tenderness is or the joint line opens up? You will use the finger. The middle finger should be placed on the medial joint line. And now you apply the valgus force to the tibia. Now if the joint line opens up on the medial side, it suggests there is an MCL injury. Or if there is a tenderness on the medial side, it suggests there is an MCL injury. This is valgus force. So this is known as valgus stress test. And this is the test to assess the integrity of the medial collateral ligament. Similarly, if you apply the varus force, the lateral joint line will open up and the patient will complain of the lateral joint line pain. This is suggestive of LCL tear, and to test it, we apply varus force. This is known as varus stress test. Now let me demonstrate on this patient. You flex the knee to 30 degrees. And upon flexion of the knee, you put your hand over here on the lateral condyles of the femur to use as a fulcrum, and then you put the middle finger on the medial side to assess the joint line opening up or tenderness. Then you take your other hand above the ankle, and now you apply the valgus force. On application of valgus force, if the medial joint opens up or if the patient complains of pain on the medial side, this is a positive valgus stress test suggestive of medial collateral ligament injury. Similarly, on application of varus force, if the patient complains of pain over the lateral side of the knee or the lateral joint opens up, it is a positive test for lateral collateral ligament injury, and this is your varus stress test. So remember, valgus stress test for MCL and varus stress for LCL. Preferably perform them in 30 degrees of flexion. So we have understood the anatomy, we've understood the function, we've understood how they get injured, we've understood how to clinically diagnose a collateral tear. Let's move on to meniscus. For meniscus, I've told you their anatomy, I've told you their function, I've told you how they get injured. Now let's see how we can test them, how we can provoke their symptoms. See, they are rotational or torsional stabilizers. To test them, to provoke their symptoms, we need to rotate the knee. We need to rotate the knee. So how will you do it? You have McMurray's test. You have Apley's grinding test. In McMurray's test, you take the patient and you flex and extend the knee. You flex and extend the knee. Now while you're flexing and extending the knee, you rotate the tibia. As you're rotating the tibia, you will notice that the injured piece of meniscus will somehow come between the tibia and the femoral condyle. Now once it comes between the tibia and the femoral condyles, the patient will scream in pain. You have provoked the symptoms, your diagnosis is complete. Right? This is your McMurray's test. There can either be pain or sometimes a clicking sound upon performing McMurray's test. Now let me demonstrate McMurray's test for you. But before I begin, let me ask you, what is it for? It is for the menisci, either the medial or the lateral menisci, the semilunar cartilaginous structures in your knee joint. Now, if you recall, what was the function or the primary function of the menisci? It was to stabilize the knee in rotation. It was the rotational stabilizer of the knee. So can you imagine what kind of provocative test we will perform to assess if it's injured or not? We'll basically try to compress the injured part of the meniscus between the femoral and the tibial condyles. The moment we compress the injured part between these two condyles, we'll either feel a click or a pop, or the patient will complain of pain. That is what we are going to do on McMurray's test. Now, in order to do this test, what we will do is, we'll first hyperflex the injured knee. We'll hyperflex it. And then we will put our fingers on the part of the meniscus that we want to examine. Now remember, menisci are located at the joint line. If we want to feel the medial meniscus, we will feel it at the medial joint line. And if we want to feel the lateral meniscus, we will feel it at the lateral joint line. Now let's start with medial meniscus, because that is the one that is more commonly injured. We'll flex the knee in hyperflexion and we'll put our index finger over the medial joint line. And what are we looking for? We are looking for a pop or a click or pain or wincing on the patient's face. Right. Now, once we have hyperflexed the knee, then we'll perform internal rotation and varus force to assess the lateral meniscus, and we'll perform external rotation and valgus force to assess the medial meniscus. Please remember this. For medial meniscus, you're applying external rotation of the tibia and applying valgus force to the knee. And to assess the lateral meniscus, you will apply internal rotation of the tibia and varus force to the knee. Are you clear on this? For medial meniscus, external rotation of the tibia and valgus force to the knee. And once that is in this position, from flexed position, you will slowly extend the knee. And you will keep on doing this extension and hyperflexion till you feel for a click or a pop on the medial joint line over the medial meniscus. And you will also be observing the patient for a wince or pain, making a diagnosis of medial meniscus injury. If you want to assess the lateral meniscus, you will apply internal rotation to the tibia and you will apply varus force, and then again from a hyperflexed position, you will extend the knee while keeping your finger over the lateral joint line, and again you will be feeling for a pop or a click or looking for pain or wince on the patient's face. This is how you diagnose medial or lateral meniscus injury, and this test is a McMurray's test. On the other hand, there is Apley's grinding test. In this test, you make the patient lie down prone, you flex the knee to 90 degrees, and then you grind on the torn meniscus to provoke the symptoms. Apley's grinding test. Now, the test that I would like to demonstrate for medial and lateral meniscus to you is Apley's grinding test. Now, it is exactly like how it sounds. It's essentially you grinding the menisci between the tibia and the femoral condyles. So all you have to do is make the patient lie down prone, and once the patient is prone, you take the injured knee and you flex it to 90 degrees. Now you need to stabilize the femur as well as the tibia. Hold the ankle with your one hand and hold the femur with the other hand. This is one way of doing it. The other way of doing it is holding the ankle with your one hand and then holding the leg with the other hand. Either way, your aim here is very simple. You need to apply force to the tibia towards the table. Right? You need to push the tibia towards the table, essentially trying to crush the injured part of the meniscus between the femoral and the tibial condyles. Now, while you're at it, while you're applying the force, you need to apply external rotation and internal rotation to bring the injured part of the meniscus between the axial force or the crushing force. This is Apley's grinding test for the medial and lateral meniscus injury of the knee. There is another test known as Thessali test, where you ask the patient to stand on the injured knee, flex the knee a little, and then twist the knee. What are you doing? You're basically trying to provoke the symptoms here. This is a provocative test for meniscal injury. This is Thessaly test. But all of these are very painful. So the best test is a joint line tenderness, where you take your finger and you press along the joint line. You take your finger and press along the joint line. The torn piece of meniscus, when you press on it, it will be painful. That's how you clinically diagnose meniscal injury. Okay, so McMurray's test, Apley's grinding test, Thessaly test, these are all there, but they are painful. Joint line tenderness is the best clinical test. Now, the best test to assess the meniscal injury clinically is a joint line tenderness. Now, what is joint line tenderness? You feel for tenderness on the joint line of the knee. How do you go about doing it? You flex the knee to 90 degrees and take your thumb or your index finger, whatever you feel like, and feel for tenderness at the joint line. Now, what is the joint line? It is the line between the distal femur and the proximal tibia, and that line is the joint line of the knee joint, right? You feel for joint line tenderness by palpating over the joint line. If there is tenderness on the anteromedial aspect, it suggests that the anterior horn of the medial meniscus is injured. If there is tenderness over the medial part, it suggests the body or the medial part of the meniscus is injured. If there is tenderness over the posteromedial aspect, it is the posterior horn of the medial meniscus that is injured. And the same thing can be related if you have tenderness over the anterolateral, lateral, and the posterolateral aspect of the joint. This is known as joint line tenderness, which is the best clinical test to diagnose meniscus injury. So we have talked about the clinical test for collaterals. We've talked about the clinical test for meniscus. What about the clinical test for cruciate? What is the provocative test for cruciate? What is the action of cruciate? Sagittal plane stability, right? So you provoke the symptoms in sagittal plane. How do they get injured? Twisting injury, hyperextension, anterior translation, hyperflexion, posterior translation, you've understood. Immediate swelling will be there. Patient will complain of instability, difficulty walking up or down the stairs. So what is the provocative test for ACL? For ACL, all you need to do is translate it anteriorly. Make the patient lie down. Flex the hip to 45 degrees and knee to 90 degrees, and you stabilize the foot by sitting on it. Okay. And then translate the tibia anteriorly. That was the action that was supposed to be resisted by ACL. And if it is torn, by doing this, it will be painful, or the tibia will translate anteriorly. This is known as anterior drawer test. Anterior drawer test. Now, can you tell me what is posterior drawer test for PCL? Same position, just translate the tibia posterior. Just translate the tibia posterior. That is known as posterior drawer test for PCL. Now, let me show you the test for anterior cruciate ligament and the posterior cruciate ligament. Now, let's start with anterior cruciate ligament. Can you recall the principal action of the anterior cruciate ligament? The principal action of anterior cruciate ligament was to provide sagittal plane stability. Can you recall what was sagittal plane? The sagittal plane was the plane where your limb moves forward and backward. So this kind of movement, stability was provided by the anterior and the posterior cruciate ligaments. Now, particularly, what was the action of anterior cruciate ligament? The action of anterior cruciate ligament was to prevent the anterior translation of tibia. Prevent the anterior translation of tibia, or to prevent hyperextension of the knee, or to prevent hyperextension of the knee. This was the action of anterior cruciate ligament. Now, if a patient comes to you with an anterior cruciate ligament tear, what are the tests that you can perform? There are two important tests that you will perform. One is the anterior drawer test. The other is the Lachman test. Let me demonstrate the anterior drawer test to you. Now, in the anterior drawer test, we'll ask the patient to flex the knee to 90 degrees. Now, some books say not the knee to 90 degrees, flex the hip to 45 degrees. Now, my friends, if you pay attention, if the knee is brought to 90, the hip will automatically go to 45. Or if you bring the hip to 45, the knee will automatically go to 90. So there is unnecessary confusion that is created. So essentially, what are you doing? You're flexing the hip to 45 and knee to 90 degrees. Now, in this position, you need to stabilize the foot. How will you stabilize the foot? Now, in order to stabilize the leg, I need to sit on the foot to hold its distal end. Sir, can I sit on your foot? Thank you. So I will sit on the patient's foot. Now the leg is stabilized because it's not going to move anywhere. Then I'll hold the tibia and put my thumb over the superior aspect of the tibia to feel the joint line, and then bring my thumbs down just a little. And then I will try to pull the tibia or translate the tibia anteriorly. Right? Now normally there should be a firm end to this translation, suggesting that the ACL is intact. Or the translation should be very minimal, very less, somewhere around 1 to 2 millimeters. If there is an ACL tear, what will happen? The tibia will translate anteriorly more than 3 or 4 or 5 millimeter. Or it will come translate anteriorly without any firm hard stop, suggesting that the ACL is torn. This is anterior drawer test. Now let me show you what is happening here. The patient has his knee flexed to 90 degrees, right? Now I am holding the tibia and trying to anteriorly translate. If the ACL is torn, the tibia will translate anteriorly, and if it is intact, the tibia will not translate anteriorly. This is anterior drawer test for anterior cruciate ligament. Now, there is one problem in anterior drawer test. When a patient injures their knee, the muscles around the knee will be in spasm, particularly the hamstring muscles. Now, hamstring muscles, if they are in spasm, what will happen? So this is where the hamstrings muscle go. Right? This is where they go. Now, if they are in spasm, what will happen? You will be unable to translate the tibia anteriorly, even if there is an ACL tear. So there is a high chance of false negativity. That is why the better test for an acutely injured ACL or acutely injured knee is Lachman's test, where you just flex the knee to 20 degrees and translate the tibia anteriorly. Now in 20 degrees, friends, the hamstrings are removed from the equation. When the hamstrings are removed from the equation, you only have ACL2 test. Okay, you apply the translation anteriorly, and if ACL is torn, the tibia will translate anteriorly. That is known as the Lachman's test. This is the best test or the most sensitive test for ACL tear. The next test for anterior cruciate ligament is Lachman's test, and it is the test that we perform in acute knee injuries. Why is that? Because you see, for an anterior drawer test, you need to flex the knee to 90 degrees. And if the patient has acutely injured their knee, flexing the knee to 90 degrees would be painful. And also recall, whenever there is pain, the muscles around the area of pain will undergo spasm. The most important muscle here is hamstrings. When these hamstrings contract or in spasm, the tibia will not be translating anteriorly because the hamstrings are pulling the tibia. Now in Lachman test, you do not flex the knee to 90 degrees. Instead, you flex it barely to 15 to 20 degrees. Now let me show you. You can flex it 15 to 20 degrees. That's the flexion that you need. Now, if you're strong enough and the patient is light enough, you can do it easily. But if not, you need something between the couch and the thigh to flex it to 15 to 20 degrees. My personal favorite is my own knee. I would just place my knee under the patient's thigh to flex it around 15 to 20 to 30 degrees. That should be fine. Now by doing this, what I have done is I have removed the hamstring pull from the equation. That is why Lachman test is the most sensitive test for ACL tear. Now what do? I hold the femur and then I hold the tibia. Obviously you're seeing which hands I'm using for which part of the body. I'm using the left hand for the thigh because it's on the outer surface, and I'm using the right hand for the leg. Then what do? I translate the tibia anteriorly. If the ACL is torn, the tibia will translate anteriorly, and if it's intact, it will not. So this is what is happening to the bones when I perform the Lachman's test. I hold the femur and then I hold the tibia, and then I try to translate the tibia anteriorly. This is what is known as Lachman's test, and if the ACL is torn, the tibia will translate anteriorly, and if it is intact, it might just translate a little, but there will be a hard end point suggesting that the ACL is intact. This is the most sensitive test for ACL tear. What about PCL tear? I've already told you, posterior drawer test, where you push the tibia posteriorly. There is another test for PCL known as Godfrey's sac test. What you do in this test is you flex both the hip and both the knees to 90 degrees bilaterally. If the PCL is torn, what will happen? The tibia will sag posteriorly, because that was the action that was resisted by PCL. If it's torn, tibia will translate posteriorly. That is known as Godfrey's sag test. Now let's look at a test for posterior cruciate ligament. Now let's recall the action of posterior cruciate ligament. The action of posterior cruciate ligament was to prevent posterior translation of tibia and also to prevent hyperflexion of the knee. So what I'll be doing is I'll be flexing again the knee to 90 degrees or the hip to 45 degrees. And then I will stabilize the foot, just like how I started the position for anterior draw test. I will sit. Can I sit on your foot? No, I will sit on the foot of the patient, stabilize the leg, and again hold the tibia. But this time what I'll be looking at is the sag of the tibia. Normally, the patient tibia is slightly anterior compared to the femur. Let me demonstrate with the bone. Normally, the tibia is slightly anterior to the condyles of the femur. You would notice that the tibia is slightly anterior to the condyles of the femur. You will notice that it is slightly anterior. But if the PCL is torn, what will happen is the tibia will translate posteriorly, or there will be a sag of the tibia. There will be a posterior sag of the tibia. And when you run your thumb, you will notice that there is a step. There is a posterior sag of the tibia because of PCL tear. And that is exactly what I am trying to assess here. Now, if there is a sag, it is obvious that it is a posterior cruciate ligament tear. But before I confirm that, I would try to first anteriorly translate and then I'll try to push it posteriorly. This is known as posterior draw test. If the tibia is translating posteriorly, it suggests that the PCL is injured. Now the other variation of this is Godfrey's posterior sag test. For this, what we'll do is we'll flex both the hips to 90 and both the knees to 90 degrees. Let's do this. Sir, can you do this? Yeah. Now we have both the hips and both the knees flexed to 90 degrees. Now if there is a PCL tear in any of the knee, what will happen is the tibia will translate posteriorly and then you can compare it with the healthy side to assess the sag. If the pathological side has a PCL tear, the tibia will sag posteriorly, and the normal side, there will be no sag, and you can compare it and say that there is a PCL tear. But please remember, it can only help you assess if there is a unilateral injury. If there is a bilateral injury, both the sides will sag and you will be confused. But please also understand that normally the tibia will not sag posteriorly. In any case, if the tibia is sagging posteriorly, it must mean that there is a PCL tear. So again, what is happening is I flex the hip to 90 degrees and the knee to 90 degrees, and because the PCL is torn, the tibia is sagging posteriorly. This is Godfrey's posterior sag test. Quickly summarize here. ACL, we have Lachman's test, the best test, the most sensitive test. Anterior draw test. Pivot shift is the most specific test, and Lely's test. For PCL, you have posterior draw test and Godfrey's sag test. These are the clinical tests or the provocative tests to diagnose cruciate injuries. So what have we read so far? We have read the anatomy. We have read their function. We have read how they get injured. We have read their clinical features. We have read how to test these structures clinically. Now coming to the radiology. What is the investigation of choice? The investigation of choice for all these ligament injuries is MRI, because MRI picks up soft tissue. What is the investigation of choice for collateral ligament injuries? MRI. MRI is the investigation of choice for collateral ligament injuries. Look at this coronal section. This is the femur. This is the tibia. This is the medial side. You notice there is edema here over the medial collateral ligament, suggesting that it is torn. Okay. Now, what is the investigation of choice for meniscal injury? MRI. MRI is the investigation of choice for meniscal injuries. They look like a tie here. Basically, say this is the meniscus. This is the meniscus. Each section of the MRI is something like this. So if you take this section, it will look something like this. So here, this is the anterior horn of the meniscus, posterior horn of the meniscus, and you notice there is a tear here in the posterior horn of the meniscus, right? So this is MRI showing you meniscal tear. But if they ask you what is the gold standard investigation, please remember gold standard will be arthroscopy, and I'll tell you in a bit why. Why? Investigation of choice is MRI. Gold standard investigation is arthroscopy. For cruciate also, investigation of choice is MRI. And what do we prefer? We prefer the sagittal view. Gold standard is arthroscopy. I'll show you. I'll just show you in a minute. Just bear with me. See, this is femur. This is tibia. This is ACL. This is PCL. If the ACL is torn, you will notice it in which view? The sagittal view. Again, look at this. ACL, PCL. PCL is there, but ACL is gone. This is ACL. Right? So MRI is the investigation of choice for all of them. But gold standard investigation is arthroscopy for intracapsular structures, not for extracapsular structures. So collaterals ka gold standard bhi MRI because they are extracapsular structures. Now why arthroscopy is the gold standard investigation? Because you see, MRI, reading MRI is subjective. There are many radiologists who will read it very well. There are some radiologists who will not, who might miss it, number one. Number two, the slices that you take on MRI might not be so good. Sometimes what happens, the injury is missed on that slice. Okay? So it's not real. There are chances of missing the slices or the pathology on MRI. So when you put a camera inside, what can beat that? You can visualize the injuries with your own eye without any kind of bias from the radiologist. So the gold standard investigation remains arthroscopy, where you put the camera inside the knee joint and visualize the injuries yourself. That way you can be accurate. That way you can be sure that the meniscus is actually injured, the cruciate is actually injured. Please remember, collateral ke liye you will not do arthroscopy because they are extracapsular structures. Okay, so far we have read the anatomy, their function, how they get injured, their clinical features, their provocative tests, their radiological investigations under 3 headings. What about the treatment now? I'll review everything. What about the treatment now? Very simple. Treatment is very straightforward. If the collaterals are injured, usually conservative would suffice. So collateral ligament injuries, conservative bracing would work for majority of the cases. Nothing to worry about. Okay? Apply the brace, the ligaments will heal because they're extracapsular structures. Now menisci. Before we understand the treatment of menisci, we need to understand a little bit of extra points of anatomy of meniscus so that it becomes easy. You see, meniscus, this semilunar cartilage, receives its nutrition from 2 sources. The peripheral part of the meniscus receives its nutrition from the genicular vessels. Okay, from the genicular vessels. This part of the meniscus we call the red zone of the meniscus. So peripheral part receives nutrition from the genicular vessels we call the red zone of the meniscus, and the central part of the meniscus receives its nutrition from the synovial fluid. We call it the white zone of meniscus. The red zone receives its nutrition, the peripheral part receives its nutrition from the genicular vessels. The central white zone receives its nutrition from the synovial fluid. They are not red in color. They are just described like that for you to understand. Okay. Now, if the injury is in the red zone, it means it is a vascular zone. If you repair it, it is amenable to healing. If the injury is in the white zone, it means in avascular zone. If you repair it, it will not heal. Simple. So red zone tear because of vascularity. If it is torn, you will repair it. White zone tear because it's not vascular. If it's torn, you will not repair it, you will remove it. So what is the terminology? Red zone tear, meniscography means repair the meniscus. White zone tear, remove the meniscus, meniscectomy. And this was asked as a question in the recent exam. Okay, so we understood the treatment of the collaterals, we've understood the treatment of the menisci. Treatment of menisci depends on the vascularity, red zone and white zone. Finally, the cruciate. What will you do for the cruciate? Cruciates cannot be repaired. You have to reconstruct them. You take the patient's own tendon, fashion it in the shape of the ligament and pass it and place it in the place of a originally injured ligament. So where do we harvest these tendons from? We harvest the hamstring tendons like semitendinosus or gracilis, or we can also use the patellar tendon. You take the tendon, you fashion it in the shape of the ligament, and then you pass it in its place. Okay, you pass it in its place. You can anchor it with the bone with any hardware that is available. There are washers, there are screws. You don't need to know that. So you basically take the patient's semitendinosus graft, gracilis tendon graft, and you put it in the place of the torn ACL and PCL. So look at this. This is preparing the semitendinosus graft. And arthroscopic view mein, you can see that we are making a hole and then you are pulling the graft. This is the graft here, and see, now we have placed it here. Okay, now we have placed it here. This is the treatment of ACL and PCL. Now before we move further, I want to review this with you because we have talked about so many things and I know you will get confused. So let me quickly review the clinical test because MCQs will come here. Clinical test review first. Collaterals. Very good. How many collaterals? Medial collateral ligament, lateral collateral ligament. What is the test for medial collateral ligament? Come on, tell me. Which stress test? Which stress test? Valgus stress test, yes. And for LCL, varus stress test. And you will perform this test in 30 degrees of flexion. ठीक है ना? So far so good? Very good. What about menisci? What is the test for menisci? McMurray's test. Very good. McMurray's test. Apley's grinding test. Thessaly test. But the best is joint line tenderness. This is me just reviewing with you. The spellings, the language and my handwriting, everything is typed there previously. You have written now. This is just me reviewing with you, right? Okay. Cruciate. You have ACL. You have PCL, right? What was the test for ACL? Anterior draw test, where you flex the knee to 90 degrees and hip to 45 degrees. The anterior draw test. Lachman test, where you flex the knee to 20 degrees, right? Anterior draw test, Lachman. Lachman test is the best test, the most sensitive test used in acute injuries, acute knee injuries. PCL, posterior draw test or SAG test. ठीक है ना? Or SAG test. ठीक है? Questions will come from clinical tests, you know. Now questions will also come from treatment. Let's quickly discuss that. First, collaterals, I have told you, we can manage it conservatively because 90% of them can be managed conservatively with a brace. So collaterals, brace is the treatment. What about menisci? Menisci, I have told you that we have divided the menisci into peripheral, red zone and the central white zone. Red zone you have to repair, meniscorrhaphy, and white zone you have to remove, meniscectomy. I've told you this, right? Meniscorrhaphy and meniscectomy. Meniscectomies can be partial or subtotal depending on the requirement. Don't worry about it. Now cruciate. What will you do? You will do reconstruction. And which tendons will you harvest to reconstruct? Semitendinosus or gracilis or patellar tendon. We've talked about that. So I've reviewed the tests. I've reviewed the treatment for you. Now, before we go further and tell you the detailed things that are there in arthroscopy, this is basically me operating, doing arthroscopy of the knee. What are you noticing? Noticing that there are portals here that we make in the joint to put instruments and the camera, and you're also noticing that there will be a monitor on which I will be observing what I am doing at the knee joint. Alright, so let me show you the instrumentation. Let me show you everything. Arthroscope and portals. See the holes that we make in the joint to pass the scope and the instrument is known as portals. Okay, for knee you make two standard portals, anteromedial and anterolateral portals. So anteromedial portal and anterolateral portal. Remember, anterolateral portal is for looking, so you will pass the arthroscope. And anteromedial portal is for mechanical instrumentation, so you will pass the instruments. So anteromedial portal, you will pass the instruments, and anterolateral portal, you will pass the arthroscope or the camera. Right. Now, what is the standard arthroscope that you will use? The standard arthroscope that you use is 4 mm 30 degrees arthroscope. 4 mm 30 degree arthroscope. So these are all advanced points. These are all advanced, slightly advanced points that I want to discuss here. Till now, whatever we have discussed is good and important, but now a little more advanced, a few more slides of advanced points, and then I will end the topic of sports injuries. Now, one more advanced point is that please understand that anterior cruciate ligament has two bundles. And we're talking about this because MCQs are asked here. There are two bundles. One is anteromedial bundle. Other is posterolateral bundle. Okay, so AM bundle and posterolateral bundle. AM and posterolateral. Please understand that anteromedial bundle is stronger. Posterolateral bundle is weaker. So whenever there is an ACL injury, which one will get injured more likely? Posterolateral bundle will get injured more likely because it is weaker. Okay, please understand this. So ACL has two bundles. Now what I want you to understand is anteromedial bundle provides the stability in flexion, relative flexion, whereas posterolateral bundle provides stability in relative extension. So for example, if your knee is translating anteriorly, or if there is hyperextension instability, or if there is an ACL kind of instability, only in extension but not in flexion, or only in flexion but not in extension, what will you think? If it's only in extension but not in flexion, you will think that the posterolateral bundle is torn. If it's only in flexion and not in extension, you will think that anteromedial bundle is torn. Right? But please understand that whenever there is an ACL injury, the first bundle to injure will be posterolateral bundle, because anteromedial bundle is a stronger bundle. If it is injured, then obviously posterolateral bundle will also be injured. Why am I telling you this? Because remember how you perform Lachman test? Lachman test was performed with just 20 degrees of flexion, whereas anterior draw test was performed in 90 degrees of flexion. So you're testing the posterolateral bundle in Lachman test, and you're testing both the bundles in anterior draw test, mostly anteromedial bundle. So Lachman test is sensitive because it will be positive even in partial tears, because posterolateral bundle is the weaker bundle, posterolateral bundle is the more commonly injured bundle, and in partial injury, posterolateral bundle will definitely get injured, and in partial injury, Lachman will be positive, anterior draw test may or may not be positive. That is why Lachman test is the most sensitive test. Okay, it stabilizes the knee relative extension. And what are we doing for anteromedial bundle? We do anterior draw test. Kuch samajh aaya? Did you understand some of it? Now the next advanced point I want to discuss is rotatory instability. Okay, this is slightly advanced. Please just bear with me. There is something known as anterolateral rotatory instability. Anterolateral rotatory instability, and something known as posterolateral rotatory instability. Okay. Now anterolateral rotatory instability occurs because of injury of ACL plus anterolateral ligaments of the knee. This is advanced, just bear with me. Anterolateral ligaments of the knee. Posterolateral rotatory instability occurs because of injury of the PCL plus posterolateral ligaments of the knee, which are known as posterolateral complex. Okay. So anterolateral rotatory instability occurs because of injury of ACL plus anterolateral ligaments, and posterolateral rotatory instability occurs because of injury of the PCL and posterolateral complex or posterolateral ligaments. Now what are the tests for this? For anterolateral rotatory instability, you have pivot shift test, and for posterolateral rotatory instability, you have dial test. So please remember this: dial test and pivot shift test for antero and posterolateral rotatory instabilities. Now, what is the mechanism of a twisting injury of the knee? So, twisting injury of the knee, what is the mechanism? First of all, your leg has to be fixed and flexed. The leg has to be fixed to the ground and the knee has to be flexed. Your leg has to be fixed on the ground, your knee has to be flexed, and on that there is rotational or torsional forces. What? Internal rotation of the femur and valgus or abduction force of the tibia. So only then you will get a twisting injury to the knee. Your leg has to be fixed to the ground, knee has to be flexed, femur has to go into internal rotation, and there has to be valgus or abduction force acting on the knee. And when this twisting happens, you injure multiple structures. These multiple structures that get injured give you a triad known as unhappy triad or O'Donoghue's triad or terrible triad or painful triad of the knee. So the structures that usually get injured are your medial collateral ligament, anterior cruciate ligament, and the medial meniscus. Right? So look at this clearly. ACL is injured here, the sagittal view. On the coronal view, you can clearly see that MCL is injured, and again in sagittal view, you will notice that the posterior horn of the meniscus is injured. So this is O'Donoghue's painful or unhappy terrible triad. So if you remember this triad, you will be able to answer 4 MCQs on the exam. The first MCQ is, what is the most commonly injured ligament around the knee? Answer is MCL. Now among the collateral, which is more commonly injured? Answer is MCL. Among the cruciate, which is more commonly injured? The answer is ACL. And among the meniscus, which is more commonly injured? The answer is medial meniscus. Now the next extra or top up point or extra edge point that I want you to remember is Segond fracture. What is Segond fracture? Segond fracture is basically capsular avulsion seen in ACL injuries. It's a capsular avulsion seen in ACL injuries. Now where does this capsule avulse from? It avulses from the proximal part of the tibia, particularly the lateral aspect. So look at this. This is the fibula, this is the tibia, and this is where the capsule is attached, right? So here the capsule avulses, and you can clearly see that there is an avulsion fracture here. There is an avulsion fracture. In CT scan, you can clearly see this part of the tibia is separated from the remaining tibia. This is your Segond fracture. It's an avulsion fracture or the capsular avulsion fracture occurring at the proximal lateral aspect of tibia. Now the last thing that I want to discuss is Insel-Salvati ratio or Insel-Salvati index. Now what is the purpose of this index? The purpose of this index is to help us understand whether the patella has migrated proximally or moved distally. A higher level of patella is called as patella alta. A lower level of patella is called patella baja. Everything is written, just understand. Now how do you do that? How do you assess this patella alta and baja with the help of Insel-Salvati ratio or index? What you do is you take a lateral view of a knee in 30 degrees of flexion. There are other modalities also, but this is the best available. What do? You measure 2 lengths. The length of the patellar ligament or the patellar tendon and the patella itself. So patellar length and the tendon length. You measure these lengths and then you make a ratio. That is the tendon length by patellar length. What is the normal ratio? The normal ratio is between 0.8 to 1.2. Okay, so tendon length by patellar length, the normal ratio is 0.8 to 1.2. Now imagine if this ratio increases, what will happen? And if this ratio decreases, what will happen? Simple way, ratio increases means the numerator is increasing. Ratio decreases means the denominator is increasing, right? So if it is less than 0.8 means the ratio is decreasing. What is increasing? What is increasing? Patellar length is increasing. That is known as patella baja. That is known as patella baja. Short tendon, patella baja. If the ratio is increasing, it means the tendon length is more. It means patella is at a higher level. So anything more than 1.2 is patella alta. Everything is written. Have you understood? Patella alta, patella baja. Why is this important? Because patella alta, a high riding patella or higher level of patella, is associated more with instability. That is what you have to remember. Okay. Measured on lateral knee X-ray with 30 degrees of flexion. You measure the tendon length and you measure the patellar length. And then you draw a ratio, tendon length by patellar length. Normal is between 0.8 to 1.2. If it is less than 0.8, it's patella baja. If it is more than 1.2, it is patella alta. So patella baja, B for baja, B for below. Patella alta is high rider or high riding patella. What is the significance? Patella alta is associated with recurrent patellar dislocation. So these are the extra things that I want you to remember. Otherwise, focus mostly on the collateral, the menisci and cruciate. Okay, know the tests, know the investigations, and know how to understand what structure will get injured based on the mechanism of injury and clinical presentation. Knowing the names of the test is probably the most important thing that you can do at this stage of your preparation. Now let's practice a few MCQs and see what we have understood so far. So let's look at the first question. Pivot shift test in knee is because of injury to PCL, ACL, MCL or posterior elbow ligament. Pivot shift test is the most specific test for ACL. Yes, it's the most specific test for ACL. What is the most sensitive test for ACL? Lachman test. What would be the most reliable and safest test for an acutely injured ACL in a knee of a 27-year-old athlete? Anterior draw test, posterior draw test, Lachman test, Steinman test. Acutely injured knee. Yes, you do not want to flex it too much. You just want to test the structure that is most easily injured. The most sensitive test for ACL, the best test for ACL, answer is Lachman test. Yes, answer is Lachman test. Very good. Posterior cruciate ligament, true statement is attached to the lateral femoral condyle. PCL, is it attached to the lateral femoral condyle or medial femoral condyle? Medial femoral condyle. So this is false. Is intrasynovial? No, it's intracapsular but extrasynovial. False. Prevents posterior dislocation of tibia? Yes, posterior translation of tibia. Relaxed in full flexion? No, it's taut in flexion. And inserted on the medial side of the medial femoral condyle? No, it's inserted on the lateral side of the medial femoral condyle. So this is also false. So correct answer is C. Okay, na? A 24 years old college student while playing hockey injured his right knee. This patient presents after 3 months with instability of the knee joint in full extension without instability at 90 degrees of flexion. The structures most commonly damaged is at 90 degrees there is no instability, but in extension there is instability. Okay, so it is basically an ACL tear. Basically an ACL tear where anterior draw test is not positive, whereas Lachman is positive. So what is injured? What is injured? The posterolateral bundle of ACL is injured. So posterolateral part of the ACL is injured. The posterolateral bundle of ACL is injured. I told you, anteromedial bundle and posterolateral bundle. Posterolateral bundle assesses the instability in extension. Anteromedial bundle provides stability in flexion. So posterolateral bundle provides stability in extension. Anteromedial bundle provides stability in flexion. So if there is instability in extension, not in flexion, it's posterolateral bundle that is injured. It's a weaker of the two bundles. It's the most sensitive test is Lachman's test. Very good. A twisting injury of the knee in flexed position would result in injury to all except. Twisting injury to the knee will injure all of the following except meniscal tear, yes. Capsular tear, possibly. Anterior cruciate ligament, yes. Fibular collateral ligament, no. Not lateral collateral ligament. It will not injure the lateral collateral ligament. So O'Donohue's terrible triad, what are the structures injured? ACL, medial meniscus and MCL. Injury from the lateral side of the knee causes damage to. There is injury to the lateral side of the knee. So this is a femur. This is tibia. This is fibula. Injury from the lateral side will injure. It will lead to femur. It will lead to tibia going in. Valgus. So what will injure? Your MCL will get injured. MCL will get injured. Okay, na? Right. Valgus force, abduction force. Structural integrity of the collateral ligaments are tested by. So what is the test for collateral ligaments? Valgus and varus stress test. Yes, all the options are valgus and varus stress test. With knee in 30 degrees of flexion or full extension? With 30 degrees of flexion, because in that position it is tested in isolation. Very good. A patient met with a road traffic accident with subsequent injury to the left knee. Road traffic accident, injury to the left knee. Dial test was positive. What could be the cause? MCL? No. Medial meniscus? No. Lateral meniscus? No. Posterolateral corner injury? Yes. Posterolateral corner injury. That is, dial test is for posterolateral corner injury. So it assesses posterolateral rotatory instability. Very good. Which of the following statements about menisci is not true? Okay. Lateral meniscus covers more tibial articular surface than medial. True. Medial meniscus is more commonly injured than lateral. True, because it is adherent to the MCL. Menisci are predominantly made up of type 1 collagen. Yes, bone and menisci are type 1 collagen. Medial meniscus is more mobile than lateral. No. Medial meniscus is not mobile. It is adherent to the medial collateral ligament. That is why it is more commonly injured. McMurray test is positive in the injury of. McMurray test is the test for menisci. ACL, no. PCL, no. Medial meniscus, yes. Popliteal bursitis, no. So the answer is C. Yes, McMurray's test, Apley's grinding test, Thessaly test, but the best test is joint line tenderness. Which is the investigation of choice for sports injury of the knee? Investigation of choice. Options are ultrasonography, plain radiography, arthrography, or arthroscopy. Actually, investigation of choice is MRI. Since it's not in the options, I'll go with arthroscopy. Arthroscopy. True regarding ligamentous injury of ankle is all except. Ankle joint is the commonest site of ligament injury. Yes, all of us have at least injured it once in life. Inversion of the plantar flexed foot is the commonest mode. Yes, that's how we injure it, right? Anterior talofibular ligament is most commonly involved in the ankle sprain. Yes, our foot goes into inversion and anterior talofibular is the one that gets injured. Posterior talofibular ligament is most commonly involved in ankle sprain. No, it is the anterior. So this is the answer. Okay. Now Ames question. All are true about PCL except. It is extrasynovial. Yes, true. Primary rotational stabilizer of the knee. No. Primary rotational stabilizer of the knee is menisci. So this is false. Originate from the anterolateral aspect of the medial condyle of the femur in intercondylar region. Yes, basically it's the lateral part of the medial condyle. Primary restraint to posterior movement of tibia. Yes, true. So what is the answer? Primary rotational stabilizer of the knee. It is basically a sagittal plane stabilizer. Rotational stabilizer is meniscus. Insel-Salvati index is used for. Insel-Salvati index is used for olecranon, patella, talus or scaphoid. It is used for patella. Why? To assess whether the patella is high riding or low. Patella alta or patella baja. Patella alta is high, patella baja is low. Patella alta will lead to recurrent dislocations of patella. Patella alta is when the Insel-Salvati ratio is more than 1.2. Patella baja is when the Insel-Salvati ratio is less than 0.8. Okay? Now, in a case of meniscal tear, posted for repair. Okay, there is a meniscal tear and it's posted for repair. Which of the following zones of meniscus shows best healing potential? Best healing potential of meniscus. Gray zone, white zone, red zone, wide red zone. Recall the anatomy. The peripheral zone is the red zone. Vascular has best healing potential. So the answer is red zone. With that, we have completed our sports injuries. This is a novel topic, but I would want you to focus more on collaterals, cruciate and meniscus, and please remember their stress tests. Questions will mostly come from there.